Thank you for joining our webinar on the ambulatory specialty model heart failure cohort. Ambulatory specialty model includes two distinct cohorts. This presentation focuses on the heart failure cohort, providing you an overview of the cohort requirements and detailed review of the applicable eligibility criteria, measure specifications, and scoring expectations. The heart failure cohort focuses on improving outcomes for Medicare beneficiaries receiving outpatient cardiology care for heart failure. Eligible clinicians are evaluated on quality and cost measures designed to promote evidence-based management, reduce hospitalizations, and enhance care coordination across the continuum of care. The included specialty in this cohort is general cardiology, and that will include providers who are actively billing under cardiology-related specialties. The excluded specialties are interventional cardiology and all cardiac subspecialties. Some of the key focus areas for this cohort is early identification and management of heart failure, optimization of guideline-directed medical therapy, reduction of acute cardiovascular-related hospital admissions, improved care transitions, and patient engagement and coordination of care among your provider and your care teams. Now let's take a brief look at an example of the financial risk associated with participation in the heart failure cohort. In this example, Heart Cardiology Clinic has one eligible provider participating in the cohort. The table illustrates the potential exposure to Medicare Part B revenue based on the provider's annual Part B billings. Beginning in 2027, participants are accountable for up to 9% of their Medicare Part B revenue. Their risk remains at 9% through 2028 and gradually increases to 10% in 2029, 11% in 2030, and 12% in 2031. For a provider billing approximately $200,000 annually in Medicare Part B services, the maximum financial exposure ranges from $18,000 in 2027 and 2028 to $24,000 by 2031, resulting in a cumulative potential risk of $102,000 over the 5-year model period. For providers with higher Medicare revenue, the financial exposure increases proportionally. A provider billing $500,000 annually could face a cumulative maximum risk of $225,000, while a provider billing $1 million annually could have a cumulative exposure of $510,000 over the life of the model. It is important to remember that these figures represent the maximum downside risk exposures and not your guaranteed losses. The actual financial performance, of course, is going to depend on the practice's ability to manage cost, to improve quality outcomes, and successfully meet the model's performance requirements. This example really highlights why understanding your attribution, your care management workflows, your quality performance, your cost reduction strategies are critical for practices that are participating in this cohort. Participants are evaluated across 4 key components: quality, cost, improvement activities, and promoting interoperability. The quality category is worth 50% of the final score. Providers are responsible for reporting and performing on key heart failure related measures, including beta blocker therapy for LVSD, ACE inhibitor ARB or ARNI therapy for LVSD, controlling high blood pressure, functional status assessment for heart failure. These measures are focusing on evidence-based treatment, symptom management, and then, of course, improving overall patient health outcomes. Moving on to the cost measure, it is also 50% of your final score. The heart failure episode-based cost measure evaluates the total cost of care associated with managing heart failure patients, emphasizing efficient and coordinated specialty care. In addition to quality and cost performance, practices must complete requirements within the foundational categories. which are also foundational categories for traditional MIPS and MVP reporting. First, you have improvement activities. Participants must successfully attest to both required improvement activities, which for this cohort focuses on social needs screening and strengthening communication and care coordination with primary care providers. You can earn a -10 or a -20 point deduction from final score calculation for incomplete attestations. For promoting interoperability, participants must use a certified electronic health record and meet all promoting interoperability requirements. Unlike some other CMS programs, automatic reweighting is not available for any special designations. For this category, you can receive up to a -10 point deduction from the final calculation. And practices that are designated as small practices may elect to submit performance data at the group level. However, if you are a large practice, you do have to submit at that individual level. So let's jump into the measures for the heart failure cohort. So the first measure is an administrative claim measure. To be scored on this measure, you have to meet a 21 case minimum and meet data completeness of 75% to earn a measure score. The measure is calculated using your claims data, meaning no additional data submission is required from clinicians or practices. Similar to the MIPS and MVP tracks, administrative claim measures are built into the measure set. For heart failure, CMS has included risk standardized acute unplanned cardiovascular related admission rates for patients with heart failure alongside with 4 other cardiovascular quality measures. The administrative claim measure includes eligible patients aged 65 years and older who have a diagnosis of heart failure or cardiomyopathy. The numerator captures acute, unplanned cardiovascular-related hospital admissions occurring during the performance period. Some key exclusions to remember: patients enrolled in hospice care, patients who have end-stage renal disease or chronic kidney disease, patients who have had a heart transplant, inotrophic therapy, and had a left ventricular assist device placed. CMS looks at lower rates of avoidable heart-related hospital stays as a sign that heart failure care is working well. So in practice, that success could come from staying ahead of your problems, providing strong outpatient care, helping patients manage their condition day to day, and making sure follow-up happens quickly after a hospital visit to keep them from needing to come back. The next 4 measures are all MIPS measures that have been part of the quality category in previous performance years. You may notice that there is 1 or 2 that you have reported on before. Each measure is worth 10 points and scoring is based on decile percentages. For the first year of the program, CMS is using real-time benchmarking across cohort participants, and they will not be using the MIPS deciles. This is for that true peer-to-peer comparison in each of the cohorts. In order to be scored, you have to meet a 20 case minimum and meet data completeness of 75% to earn a measure score. All of the measures in this cohort should be reported, but you can choose between ECQMs or MIPS CQMs depending on your reporting capabilities. It's going to be imperative that if you want to use ECQMs, you have to have a vendor that can support all of those measures. Otherwise, you will have to do a mix of both measure types, which may involve an outside registry to be able to report. The first measure included in the heart failure cohort is beta blocker therapy for left ventricular systolic dysfunction. This measure evaluates whether patients with heart failure and reduced LVF are prescribed evidence-based beta blocker therapy. The measure applies to patients 18 years and older with a diagnosis of heart failure who had at least 2 qualifying encounters during the performance period and a LVEF greater than or equal to 40%. The numerator is met when the patient is prescribed or is actively taking an approved beta blocker medication for the treatment of LVSD. Patients with history of heart transplant or LVAD prior to the end of the outpatient encounter with moderate or severe LVSD are excluded from this measure. So thinking about a few key steps that can help boost performance in this measure: identifying your heart failure patients early, reviewing medications before visits, leveraging EHR alerts, and ensure beta blockers are prescribed and documented. Quality measure in the heart failure cohort is ACE inhibitor, ARV, or ARNI therapy for LVSD. The measure evaluates whether patients with LVSD are appropriately treated with evidence-based medications that improve survival and reduce hospitalizations. The measure applies to patients 18 years and older with a diagnosis of heart failure who have had at least 2 qualifying encounters during the performance period and a LVEF greater than or equal to 40%. The numerator is met when patients are prescribed or take ACE inhibitors or ARV, ARNI therapy. Patients with history of a heart transplant or with LVAD prior to the end of the outpatient encounter with moderate or severe LVSD are excluded from the denominator. So a few simple proactive steps can really make a difference in improving this measure. Try planning ahead before visits, using your EHR reminders to stay on track, following up with patients while providing education. These efforts can really help increase appropriate use of ACE, ARB, and ARNI and improve overall care.
Another one of the 4 clinical quality measures included in the heart failure cohort is controlling high blood pressure. This measure is going to evaluate the percentage of patients between the age of 18 and 85 who have had a diagnosis of hypertension and whose most recent blood pressure during the measurement period is adequately controlled. This means that it is less than 140/90. For organizations participating in this cohort, blood pressure management is going to be particularly important because hypertension is one of the leading contributors to both the development and progression of heart failure. Poor blood pressure control can accelerate disease progression and lead to more frequent exacerbations, hospitalizations, and emergency department utilization. Patients are included in this measure if they have a diagnosis of essential hypertension and had at least 1 qualifying visit during the measurement period. Performance is based on the most recent blood pressure that is documented in the patient's record. There are several exclusions within this measure, and those include the patient receiving palliative care or hospice services during the measurement period, patients with end-stage renal disease, those receiving dialysis or a kidney transplant, pregnant patients, and certain older adults with documented frailty along with long-term nursing home residency. From a population health perspective, reliable workflows for blood pressure measurement, timely follow-up for uncontrolled readings, medication optimizations, patient self-monitoring, and care management outreach are going to be crucial to improving performance for this measure. These interventions are not only going to improve measure performance, but they can also support better outcomes for your patients living with heart failure. The final measure included in the heart failure cohort is functional status assessment for heart failure. This measure evaluates whether patients with heart failure have documented patient-reported functional status assessment within their record. Eligible patients are adults age 18 and older with a diagnosis of heart failure who have had at least 2 encounters during the measurement period. Unlike many traditional quality measures that focus on laboratory values or clinical outcomes, this measure is going to focus on the patient's perspective of their health and daily functioning. Functional status assessments help providers understand how heart failure symptoms are affecting a patient's ability to perform everyday activities and maintain their quality of life. To meet this measure's requirements, organizations must document the results of the patient-reported functional status assessment using a standardized tool. It's important to utilize a validated heart failure-specific assessment tool for this measure. Patients receiving hospice care or those with severe cognitive impairment are excluded. And within the ambulatory specialty model, this measure is important because changes in functional status often occur far before more serious clinical deterioration becomes apparent. This measure is going to shift the focus from how the heart is functioning to how the patient is functioning. Regular assessment can help identify patients whose symptoms are worsening, provoking earlier intervention, and potentially preventing emergency department visits, hospitalizations, and further disease progression. Along with the quality measures we've discussed, participants in this cohort will also be evaluated on a heart failure episode-based cost measure. Unlike the quality measures, this measure is calculated entirely from Medicare claims data, and it's going to include spending across Medicare Parts A, B, and D. Organizations do not submit any additional data for this measure. This measure is going to evaluate the total cost of care associated with heart failure episodes attributed to participating clinicians, and will compare each organization's high-risk adjusted spending against a national benchmark to determine performance. A minimum of 20 attributed episodes is required for scoring, and because the cost category represents 50% of the overall cohort score, performance in this area is going to be substantial and have a great impact on success within this model. The goal is not simply to reduce spending. Instead, CMS is evaluating whether organizations can deliver high-quality care and avoid unnecessary utilization and preventable cost. Historically, the largest cost drivers for heart failure patients include inpatient hospital admissions, readmissions following a hospitalization, emergency department utilization, skilled nursing facility stays, high-cost imaging procedures and specialty services, and medication-related issues like poor medication adherence that leads to disease exacerbation. Because of this, organizations that perform well on cost measures typically focus on preventing avoidable deterioration rather than reducing services. So moving on to scoring and benchmarking. One of the biggest differences between the ambulatory specialty model and traditional MIPS scoring is how the performance is benchmarked. So right now under MIPS, participants are generally compared against established historical benchmarks. Organizations generally know in advance the level of performance that is needed to achieve a certain score. With ASM, they're going to use a different approach. So for both quality and cost, CMS is going to use cohort-specific benchmarking. So rather than comparing participants against a historical benchmark like MIPS, organizations are going to be compared against other participants within the same specialty cohort during the performance year. For year one, quality measure scoring will primarily use real-time benchmarking, and their performance is going to be evaluated relative to how other organizations in the heart failure cohort are performing for all of those measures. CMS has indicated that in future years they may transition to a more historical benchmarking approach, and that's as additional performance data becomes available. The cost category will also use real-time cohort-specific benchmarking as well. So once all the quality and cost scores have been calculated, CMS is then going to determine a final score for each participant. The median final score is going to become the dividing line for your payment adjustments. So organizations scoring above the median are going to receive a positive adjustment. Organizations scoring below the median are going to receive a negative adjustment, and those scoring at the median are going to receive a neutral adjustment. Success in ASM is not going to be determined by meeting a fixed target, but instead it's going to be determined by outperforming the median participant within your specialty cohort. Because performance is relative to other participants, organizations should focus less on achieving a specific score and more on continuous improvement throughout the year. The stronger your performance relative to your peers, the greater your opportunity for a positive payment adjustment at the end. As we wrap up today's overview, I'd like to leave you with several key areas of focus that can help prepare for success within the heart failure cohort. The first one is going to be financial monitoring. Understanding where heart failure-related costs are occurring is going to be critical, and these are going to include monitoring hospital admissions, emergency department utilization, readmissions, and other drivers of episode spending. Identifying these patterns and opportunities for early intervention can have a substantial impact on cost performance. Second, strong care coordination will be essential. Heart failure patients often receive care from multiple providers across different settings. Successful organizations should create reliable communication pathways between primary care, cardiology, care management teams, and other specialists to ensure patients receive coordinated and proactive care. Third on the list is organizations focusing on optimizing heart failure management. This includes increasing adherence to therapy guidelines, improving chronic disease management workflows, and implementing processes for ongoing symptom monitoring and early intervention when a patient's condition can begin to worsen. Also, identification of high utilizers of care, meaning those with frequent hospitalizations and ED utilization, can help to sharpen focus on who within your patient population needs additional support. So next on the list is interoperability. This will be an important area of focus. Organizations should leverage any and all technology, including health information exchanges, EHR integration, patient portals, and remote monitoring tools to improve visibility across the continuum of care and support timely clinical decision making. And finally, last on the list is beneficiary engagement. Patients play a critical role in heart failure management. Educating patients on symptom recognition, medication adherence, and self-management strategies can help prevent avoidable complications and reduce unnecessary utilizations. Ultimately, organizations that succeed in the heart failure cohort are going to be those that proactively manage patients across the continuum of care rather than simply responding to acute events as they occur. So when we look across both the quality measures and the cost measure, one thing becomes pretty clear. Success in this cohort is really about managing your patient population proactively. It's not about just documenting that care was provided. Organizations that identify high-risk patients early, coordinate care across the team, and keep patients engaged, they're going to be those that are in the best position to improve quality, outcomes, and overall cost performance. I hope this overview has given you a better understanding of what the heart failure cohort is designed to accomplish and the types of strategies that will be important for success. While there are still many details to come as CMS continues to release additional guidance, now is a great time to begin evaluating your workflows, identifying opportunities for improvement, and thinking about how your organization can prepare. If you have any questions about anything we've covered today, or would like to discuss what participation might look like for your organization, please don't hesitate to reach out. We would be happy to help here at the REC. Thank you for joining us today, and we appreciate your time.